Let us see breath sounds. Breath sounds classified into normal breath sounds called as vesicular, abnormal breath sounds called as bronchial breath sounds. So these vesicular breath sounds are generally low pitch and soft sounds. These are heard over healthy lungs. These are heard over healthy lungs. Whereas bronchial breath sounds are usually high pitch, loud sounds, high pitch and loud, high pitch and loud, high pitch and loud, similar to tracheal sounds, and these are heard over diseased lungs. These are heard over diseased lungs. So this is the difference between vesicular breath sounds, which are normal, low pitch and soft, whereas bronchial breath sounds, these are high pitch, loud, similar to tracheal sounds. So these are generally heard over diseased lungs. To understand this better, let us see the genesis of the breath sounds. So in your airway, there is a large central airway called as trachea. Whenever you put your stet directly on the trachea, what will be the nature of sound? So generally it will be high pitch and loud. It will be high pitch and loud. When the same sound reaches the alveoli, it will be low pitch and soft. The most important reason is alveoli effectively filters sound. Alveoli effectively filters sound. Now what is the logic behind this? Now your trachea is a large central airway. Air flowing in it will have more turbulence, whereas your alveoli, there are millions of alveoli. By the time sound reaches from the trachea to the alveoli, the sound will be filtered in majority of the airways, and there will be that high pitch will become low pitch and the loud sound will become soft. It is just like flow of water in a river versus a canal. So whenever there is a river, water is flowing, the sound heard will be of greater intensity. So you can consider trachea as the river of water flow or river of air. Whenever that river divides into tiny small canals, so in the canals also water will flow, but the sound produced is very less. So in the same way, on the trachea you will have high pitch loud sound, whereas alveoli you will have low pitch and soft sound. Now because of some disease, again this high pitch and loud sound, if it reappears on the lung, if high pitch and loud sound reappears on the lung, it is called as bronchial breathing. Let us see the conditions responsible for bronchial breathing. So first condition is consolidation. A part of lung is getting solidified. Consolidation. It generally happens because of pneumonia. Now what is this consolidation specifically, students? You must be knowing the stages, pathological stages of pneumonia. Stage of exudation, red hepatization, gray hepatization, resolution. What is meant by hepatization? Hepatization means your lung is becoming liver-like. Liver, is it a solid organ or gas-filled organ? It is solid. Liver is solid. So your lung is becoming solid like. Pathologically it is called hepatization. Clinically it is called as consolidation. You must be knowing solids are the most effective conductors of sound. So whenever there is a consolidation area, the sound in that will be conducted with more intensity. So because of this, solids are effective conductors of sound. There will be a bronchial breath sound, and this bronchial breath sound is given a special name called as tubular breathing. The bronchial breath sound in consolidation has a special name called as tubular breathing. It will be as if you are blowing through a tube. It will be of this nature. So consider this is a tube. Bronchial breathing in consolidation will be as if you are blowing through an hollow tube. So that type of breathing is called as tubular breathing. Now coming to the next disease. So here what happens is a cavity. So what is a cavity? What is a cavity, students? So these alveoli, so they will be destroyed and they form an uniform air filled space like this. So these alveoli, they get destroyed and they form an uniform air filled space like this, which can have communication to the bronchus. An uniform air filled space which can have direct communication to the bronchus. So all these alveoli can be damaged and they form an uniform air filled space which can have communication to the bronchus. So this area is called as cavity. So in cavity there will be bronchial breathing. So in cavity there will be a bronchial breath sound. So this bronchial breath sound in cavity, it is called as cavernous breathing. It is called as cavernous breathing. So what is the reason for cavity to produce a cavernous breathing? Very simple. Previously, let us say this is the bronchus and these were all the alveoli. So there were so many alveoli. So whenever air was coming into the bronchus, it was getting filtered in this alveoli because there were so many parts. The intensity of sound was reducing eventually. Now in cavity what happens is all these alveoli are destroyed and it forms an uniform air filled space. So this is the cavity. Now what happens, this air will now come into the bronchus. Into the bronchus it goes into the cavity. Previously here there were multiple alveoli which were filtering this sound. We know that alveoli effectively filter sound. You know that alveoli effectively filter sound. Now these alveoli are lost. Everything is formed into an uniform area. So there is no filtering of this sound. From the bronchus, the air will be conducted into the cavity and there will be no reduction of intensity. So this phenomena is called as bronchial breath sound, and because it is happening in cavity, it is called as a cavernous breathing. Cavern means cavity. So how will it be similar to? It will be similar to as if somebody is blowing into a small bottle. So this is a small bottle. If you blow into this, you will get some high intensity sound. So it will be similar to that. So cavernous breathing is similar to blowing into a small bottle. Now if there is a very large cavity, nowadays we are not seeing such large cavities because we are having effective treatment for tuberculosis. So previously in the old days, what was happening was there was no treatment for tuberculosis. So there were very, very big cavities formed like this. So that cavity was generally occupying a whole lobe of the lung. So very big cavity. So very big cavity with a communication to the bronchus. So direct communication to the bronchus. A big cavity with communication to the bronchus. So in very large cavities, what will happen is again there will be a bronchial breath sound. and this bronchial breath sound will have more blowing cavity, more blowing quality. So with more blowing quality, along with that there can be a metallic quality also. In some books this more blowing quality is described as metallic quality, and this bronchial breathing in a very large cavity, it is called as amphoric breathing. So very large cavity. It was seen in early 1900s when there was no proper treatment for tuberculosis. Patients used to have very big cavities occupying a complete lobe of lung. Now how will this sound appear? So it is similar to blowing into a large jar or bottle. See, bronchial breath sound in cavity is equivalent to blowing into a small bottle. So this is equivalent to blowing into a big bottle or a jar. You will have some metallic quality also. So actually amphorous means a jar. So because it is similar to blowing into a jar, this is called as amphoric breathing. So you should know, in consolidation there is tubular breathing, consolidation, tubular breathing, cavity, cavernous breathing, blowing into a small bottle, very large cavity blowing into a big jar, it is called as amphoric breathing. Apart from this, whenever there is consolidation or cavity, there can be additional findings. Now if I ask the patient to tell 1 1 and I auscultate his chest, this finding is called as vocal resonance. Whenever there is consolidation or cavity, on the side of consolidation or cavity, now if I ask the patient to tell 1 1, on the normal side it will be audible as 1 1. On the side of consolidation or cavity it will be audible as 1 1. So this increased intensity of vocal resonance, it is called as bronchophony. So next important finding, there will be increased intensity of vocal resonance. This increased intensity of vocal resonance, it is called as bronchophony, because that area is conducting sound more effectively. Now instead of asking the patient to tell 1 1 loud, I ask him to whisper like this, 1 1 1. Generally healthy lung cannot conduct whispered sounds. Whenever there is a consolidation or cavity, even the whispered sounds can be very well conducted on that area. See, if I ask the patient to whisper like this, 1 1 1, on the healthy lung if you put your steth, you are not going to listen anything. But if there is a consolidation or cavity, even that whispered sound can be clearly heard by your stethoscope. This phenomena is called as whispering pectoralici. Increased perception of whispered sounds, increased perception of whispered sounds. So this is called as whispering. This is called as whispering pectoralici. This is called as whispering pectoralici. Now in few, not only the intensity can change, but also the quality of sound can be changed. So change in quality of E to A. So I ask the patient to tell E. On the normal side it will be audible as E only. But on the side of consolidation or cavity, so in that area of consolidation or cavity, if the patient says E, to my steth it will be audible as A. He says E. In my steth it will be audible as A. This change in quality from E to A, this is called as egophony. So the exact mechanism is not clear. So we don't know exactly why it is happening in few. So why it is happening? So whenever students, there is consolidation or cavity, apart from the bronchial breath sound, you can also expect bronchophony whispering pectorlici, egophony. So presence of bronchophony, whispering pectorlici, egophony or bronchial breath sound. What does this indicate? This indicates there is a part of lung which is conducting sound very effectively. What might be the reason? It can be either consolidation or cavity. So if you find either bronchial breathing, bronchophony, whispering pectorlici or egophony, it indicates that there is a part of lung which can conduct the sound very effectively. So what are the diseases which can conduct the sound very effectively? One is consolidation, other is cavity. Apart from this, normal and abnormal breath sounds, there are also additional sounds. So let us see what are the additional breath sounds that you should know. You should know the additional breath sounds called as wheeze on one side, on other side crepitations, crackles, also called as rails. So let us start with wheeze. So wheeze is a musical sound. It is a musical sound signifying, airflow limitation. It is a musical sound signifying airflow limitation. How is this heard? Now for example, you have taken a pen cap and you are blowing air into it. When you blow air into it, you will get a whistling sound. So why that whistling sound is audible? Because air is trying to flow across an obstruction. So whenever air tries to flow across an obstruction, there will be a whistling sound. So this whistling sound is called as wheezing. And this wheeze, it can be classified into two types based on the mechanism. We can call it as a monophonic wheeze and other is a polyphonic wheeze. A monophonic wheeze and other is a polyphonic wheeze. You must be knowing an instrument called as guitar. If you strike one string, the sound will be different. If you strike all the strings together, the sound will be different. Monophonic wheeze means striking a single string. It means a single airway is involved, that is creating wheeze. Polyphonic means simultaneously multiple airways are involved, that is creating wheeze. So in monophonic wheeze, this is due to localized airway involvement. This is due to localized airway involvement. Example, a tumor in bronchus. Example is a tumor in bronchus. Whereas polyphonic wheeze, this is due to diffuse airway involvement. This is due to diffuse airway involvement. Now can you tell me, students, in which disease simultaneously multiple airways are narrowed and creates wheeze? One is asthma and other is COPD. We also have another term called as rhonchi. In many books they use wheeze and rhonchi as synonyms, but there is a slight difference. Low pitched wheezes are generally called as rhonchi. So it is a bit difficult to differentiate with your normal ear. It requires some sound analysis, but know this difference. Rhonchi is generally low pitched wheezes. Now coming to crepitations, crackles or rails. They can be classified based on the mechanism into coarse crepitations and other is fine crepitations. Coarse crepitations and other will be fine crepitations. Coming to coarse crepitations, so these are coarse crepitations. These are bubbling sounds due to airflow into secretions. Now suppose you are having a bottle filled with water. and you are putting a straw into it and blowing some air. So whenever you put a straw and blow air into it, so that air, when it flows into secretions, it gives a bubbling sound. This bubbling sound is called as coarse crepitation. Now tell me students, in which disease your bronchus can be dilated like a straw, and always because of infection there will be secretions? Bronchiectasis. Coarse crepitations, the excellent example is bronchiectasis. Now fine crepitations, these are finer sounds. They are finer popping sounds due to sudden inspiratory opening, due to sudden inspiratory opening of previously closed alveoli. Let us see how the fine crepitations are taking place. Normally at expiration, your alveoli will be partially open like this. What is the reason behind that? Because in the alveoli there is a substance called as surfactant keeping it open. Whenever there is inflammation or fluid in and around alveoli, whenever there is inflammation or fluid in and around alveoli, this inflammation will not allow the surfactant to function properly. Because of this, alveoli will close at expiration. This inflammation will not allow surfactant to function properly, so alveoli will close at expiration. During the next inspiration, all these closed inflamed alveoli will now suddenly open. With a popping sound. So this popping sound is called as fine crepitations. These popping sounds are called as fine crepitations. Now you should get a doubt, why in normal individual fine crepitations are not happening. See, in normal individual, always at expiration, your alveoli are partially open. So whenever there is a disease in alveoli which can cause inflammation in and around alveoli, this will not allow the surfactant to function properly. So alveoli will close at expiration. During the next inspiration, all these closed alveoli should now open forcibly. When they open forcibly, they create a popping sound. This popping sound is called as fine crepitation. So this popping sound is called as fine crepitations. So what are the diseases responsible? It can be seen in pneumonia, fibrosis, pulmonary edema. Pneumonia, fibrosis, pulmonary edema. Very importantly, in interstitial lung disease. In interstitial lung disease, these fine crepitations are given a special name called as Velcro crepitation. So they are given a special name called as Velcro crepitations. Now what is the reason behind this? What is meant by Velcro, students? Velcro means a strap like this. So Velcro means a strap like this. So whenever I open this strap, can you hear a popping sound? Yes. So the person who has first identified fine crepitation in ILD felt it was similar to opening of a strap. So he called it as Velcro crepitation. So this is regarding the differences between wheeze, crepitations, crackles, also called as rales. Now with this background, Let us see clinical entities in respiratory medicine. The clinical entities in respiratory medicine. The clinical entities can be divided into pulling lesions, pushing lesions, and in between we have no push, no pull. What are the pulling lesions that we have come across previously? There is collapse and other is fibrosis. Pushing lesions we have pleural effusion, PLEF, pneumothorax, no significant pull or push of the mediastinum. What we have here is consolidation. Now I am going to differentiate these clinical entities. I am going to differentiate these clinical entities with help of percussion, auscultation, chest X-ray findings. Now coming to percussion, let us see what is normal percussion. So if I percuss on my healthy lung, you get a resonant note. So if you consider this is the level of normal lung resonance, if you consider this is the level of normal lung resonance, anything more than that, it is called as hyper resonant or tympanic note. Anything slightly less than normal lung resonance, it is called as impaired note. Still less, it is called as dull note. Maximum dullness, it is called as stony dull note. So stony dull note indicates presence of fluid within the pleural space. If this is normal lung resonance, anything more than that, hyper resonant or tympanic. Slightly less is impaired. Still less, dull. Maximum dullness is called as stony dull note. Now coming to collapse. Now what is collapse? Collapse means there is no air at all. So if you percuss in that area, because there is no air, what do you get here, students? We are going to get a dull note. Now because air is not flowing, breath sounds will be absent. See, for breath sounds to happen, air should be flowing. Now on the chest X-ray, what will be the opacity? In collapse, it is airless lung filled. Any area where there is no air, what will be the color? It will be white, and it will be no air, so it will be very homogeneous. So it is white and homogeneous. It will be completely white, homogeneously white. Now coming to fibrosis. Fibrosis is not complete absence of air. It will be presence of less air, because still some air is present. So if you percuss, it will be not normal resonant note. It will be something slightly less than normal resonant note. So this note, it is called as an impaired note. And because still some amount of air is flowing, breath sounds will not be absent. It will be diminished. Coming to the chest X-ray, because it is having less air, it will also be white. But when compared to white of collapse, it will be bit less white. So it will be white and heterogeneous, not completely white. White and heterogeneous. Coming to pleural effusion. Pleural effusion is a fluid within the pleural space. Fluid will give maximum dullness. Maximum dull note. So there will be stony dull note. Depending upon the amount of fluid, breath sounds can be diminished to absent. Breath sounds can be diminished to absent. Now chest X-ray. It is fluid within the pleural cavity. So fluid will be white. Because it is within the pleural cavity, you get a meniscoid fluid level. What is this meniscoid fluid level? I will show you in a chest X-ray, you will understand. White with meniscoid fluid level. White with meniscoid fluid level. Now coming to pneumothorax. Coming to pneumothorax. This pneumothorax is air in the pleural space. If you percuss, you get an hyper-resonant note. Hyper-resonant note. Also called as a tympanic note. Tympanic note. Depending upon the severity of pneumothorax, breath sounds can be diminished to absent. Now you should get a valid doubt. This is air, but still breath sounds are diminished to absent. What is the reason? Now whenever there is pneumothorax, there is excess air in the pleural space. This air will start compressing the lung. This air will start compressing the lung. See, for breath sounds to happen, air should be flowing within the lung. Now because lung is getting compressed by the pneumo part, so air will not flow into the lung. Because air is not flowing in the lung, breath sounds will be diminished to absent. Then coming to the chest X-ray feature. This is excess air in the pleural space. So whenever there is excess air in the pleural space, so it will be a blackish abnormality. Anything black is also called as hypertranslucency. There will be an hypertranslucent area. There will be a hypertranslucent area. Now this air in the pleural space is compressing the lung. So along with hypertranslucent area, you should also identify the compressed lung margin. You should also identify the compressed lung margin. When you see the chest X-rays, you will understand all this very well. So there will be hypertranslucent area with compressed lung margin. Next we have consolidation. Now what is consolidation? It is infection in lung parenchyma. Because of infection, alveoli might be filled with fluid. So if you percuss in consolidation, you are going to get a dull note. Auscultation in consolidation will produce bronchial breath sounds. So whenever there is an area of increased sound conduction along with bronchial breath sounds, what all you can see? We can see bronchophony, whispering, pectorlici. All these mechanisms we have just discussed. Egophony. Whenever there is consolidation in auscultation, we can find bronchial breath sounds, bronchophony, whispering pectorlici and egophony. Now coming to the classical chest X-ray feature in consolidation. To understand this, you should know the pathophysiology of pneumonia. So generally pneumonia happens because of some bacterial infection. So these bacteria will reach the alveoli and it will start proliferating. So to fight against the bacteria, your body is going to mount an immune response. So interaction between bacteria and your immune response will result in production of some secretions. So because of secretions, patient will develop cough. So because of infection, he will have fever. Because of secretions, he will develop cough, and these secretions will be sent out as sputum. So important features are fever, productive cough. Now if you see in a normal individual, the bronchus in a chest X-ray, bronchus and alveoli cannot be differentiated as two different structures, because bronchus is filled with air, alveoli is also filled with air. In a chest X-ray, when there are two structures with same density, you cannot differentiate them as two different structures. Whereas in consolidation, alveoli is starting to fill with secretions. So secretions will give whitish density. Now alveoli have become white. Now against this whitish background, air in the bronchus is clearly visualized. So this phenomena of visualizing air in the bronchus is called as air bronchogram sign. So previously, why air bronchograms were not seen? Because previously bronchus was black, alveoli was black. Now what has happened in consolidation? Alveoli is filling with secretions. So it is becoming white. Against this whitish background, now air in the bronchus can be clearly seen. This phenomena is called as air bronchogram sign. So write down, in consolidation, most important is air bronchogram sign. Most important is air bronchogram sign. Air in bronchus, clearly visualized. Air in bronchus, clearly visualized against secretions filled alveoli. Air in bronchus clearly visualized against secretions filled alveoli. Now important point about all these clinical entities is, important feature about all these clinical entities. So we have discussed previously, to identify the diseased site, students, let it be any of this clinical entity, you should always identify the side of decreased chest movement. So write down this for completion sake. Let it be any of this clinical entity. I am writing it in red. And also it's bold. So to identify diseased side, always localize side of diminished chest movements. Always localize side of diminished chest movements. So you can underline this. To identify diseased side, always localize side of diminished chest movements. Very, very important point. To identify diseased side, always localize side of diminished chest movements. To identify diseased side, always localize side of diminished chest movements. So students, whenever you see collapse, it is a pulling lesion, and on the chest X-ray you should identify white homogeneous density. Whenever you see fibrosis, it is a pulling lesion. On the chest X-ray you should be able to identify white heterogeneous area. Whenever you see a pleural effusion, it is a pushing lesion. You should be able to identify white with meniscoid fluid level. Whenever you see a pneumothorax, it is a pushing lesion. You should be able to identify hypertranslucent area with compressed lung margin. Whereas consolidation, there will be no push or no pull. Consolidation, there will be no push or no pull. What you should identify? You should identify air bronchograms. Now keep these findings in your mind. Now I'll show you various chest X-rays. and CT scans. So I will help your eyes to recognize all these findings. So let us see how to identify these on chest X-ray. They are saying that this can be consolidation. So whenever they give you any chest X-ray, first thing what you need to see is whether it is a pulling lesion or pushing lesion. So the trachea is not much deviated, and if you see the heart border, 1/3 is on the right, 2/3 is on the left. So the position of the heart is maintained. So there is no push or no pull. Now we are seeing a density here. You feel it is consolidation. How to exactly tell it is consolidation? Within that density, to call it as consolidation, you should be able to notice that air bronchogram sign. So can you see some branched bronchi within that density, students? Can you see here? These are all the branched bronchi. Same thing you can also see on a CT chest. So this is the normal healthy lung. This is the diseased lung. All these whitish areas are nothing but alveoli filled with secretion. And against this whitish background, can you see branched airways here? Can you see branched bronchi? This is nothing but air bronchogram. To call it as consolidation, no significant mediastinal shift, and you should be able to identify those air bronchograms. Now this is the collapse of lung. How did I tell? If I notice here, I could see trachea going towards the left, and most important is the heart shadow. So nothing is on the right, everything has been pulled towards the left, and moreover you are able to see a density on the left. Now if you look into this density also, there you cannot identify any air shadows. So there are no air bronchograms. It is completely white, densely white. Same thing you can see on a CT chest. This is right lung, this is left lung. Now if you notice here, this is the part of the lung that has underwent collapse. It is completely white. Pulling lesion, homogeneous whitish density is collapse. Now students, keep this white in your mind and compare the white of consolidation. Now your eyes will automatically recognize air bronchograms. Now compare this with white of here. Now in this white you can see blackish lines called as air bronchograms. That is consolidation, no mediastinal shift. Whereas this is completely white with mediastinal shift. Even if you see in that white, you cannot see those black lines called as air bronchograms. So complete white with mediastinal shift, this is collapse of lung. Now with this background, can you tell me the diagnosis of this chest X-ray? So the clue is the disease is on the right side. Now if you see, the left lung is completely filled with air and expanded. So whereas the right lung, it is not properly expanded. You can see the volume of the right lung has decreased. The diaphragm is also coming up. The trachea is pulled towards the same side. The trachea is pulled towards the same side. And what you can see here is, whitish area. And this whitish area, is it homogeneous or heterogeneous? It is not densely white. It is heterogeneous. So it has to be right fibrosis. So you can see there is a right pulling lesion, right side disease, right side the trachea is pulled, and it is right heterogeneous. It is right heterogeneous density. The answer should be fibrosis. Now this patient is having a pneumothorax. How to exactly call it as pneumothorax? You should identify air filled hypertranslucent area. So this is air filled hypertranslucent area. Against this, can you see compressed lung margin, students? Can you see compressed lung margin? Yes. To call it as pneumothorax, you should identify that air filled hypertranslucent area against that compressed lung margin. If you keenly see, there is also mediastinal shift because pneumothorax is a pushing lesion. Can you notice this, students? Air filled hypertranslucent area with compressed lung margin, This is characteristic of pneumothorax. To make you understand better, see in this also you are able to identify air filled area. Against that there is compressed lung margin. Can you notice this compressed lung margin? Same thing. On a CT scan, right lung is appearing near healthy. Left lung, what do you see? This blackish area is all air. Against that, what you notice? Compressed lung margin. So students, to identify it as pneumothorax, you should not only identify the air filled area, you should also identify that compressed lung margin. Now this is a pneumothorax. How did I tell this as pneumothorax? If you notice, the trachea is going towards the left, and also the heart shadow is towards the left, more towards the left, and you can see a density on the right. So it is a right pushing lesion. And what is the consistency? It is white with meniscoid fluid level. So it is a right pushing lesion because there is mediastinal shift. there is mediastinal shift, and also that meniscoid fluid level. You can see this meniscoid fluid level. This is the meniscoid fluid level. So this is suggestive of a right pushing lesion because it is white with the meniscoid fluid level. It indicates fluid. So it is called as right pleural effusion. So many students ask me, what is the reason for that meniscoid fluid level? So it is very simple. Whenever there is excess fluid in the pleural cavity, so your body as a defense mechanism will try to reabsorb that fluid. So reabsorption can be done through axillary lymphatics. Always axillary lymphatics will be creating a suction pressure trying to pull up the fluid into its drainage. Because axillary lymphatics are trying to pull up the fluid, so you can see that meniscoid fluid level high up into the axilla. So it is just a defense mechanism of body so that this fluid can be drained into the lymphatics. So more than that there is no special explanation. So you see whitish density, mediastinal shift. Now you might get a doubt, sir, even in collapse you have shown us a whitish density. Why this is not collapse? Because if it has been collapse is a pulling lesion. Trachea should have been pulled towards the same side. But here trachea has been pushed towards the opposite side. So this is a right pushing lesion suggestive of pleural effusion. Sometimes both fluid and air can coexist in the pleural cavity. Both fluid and air can coexist in the pleural cavity. What is that entity called as? Hydropneumothorax. No doubt this is a hydro part, this whitish area, this fluid level. To call it as pneumo part, you should not only identify air, you should also identify the compressed lung margin. You should identify the compressed lung margin. So this is the compressed lung margin. Because of air and fluid, your lung has been compressed to this quantity. Coming to the clinical findings in hydropneumothorax. Clinical findings in hydropneumothorax. Now consider this is a bottle completely filled with water. This is equivalent to pleural effusion. Now let me convert this into hydropneumothorax. Hydropneumothoraxes generally are made like this only, hydrogenic. Whenever I ask my postgraduate to get some sample from the pleural cavity, he will pierce the pleura, and sometimes he will insert the needle very deep and damage the lung parenchyma. Already there is fluid within the pleural space. Now because of damage to lung, air escapes. So it becomes hydropneumothorax. Coming to the clinical findings of hydropneumothorax. Now wherever there is air, if I percuss, I get a resonant note. Wherever there is fluid, I get a dull note. So what I do is anteriorly I start percussing. Anteriorly I start percussing. Resonant note, at the fluid, dull note. Then in the mid-axillary plane, resonant note, dull note. And in the posterior posterior portion of the chest, resonant note, dull note. Now if I join these 3 points, I get straight line of dullness. Now I'll ask the patient to comfortably sit. I will percuss in the mid-axillary plane. When I percuss in the mid-axillary plane, so where there is air, resonant, at the fluid level you will get a dull note. Now I ask the patient to shift his position like this. So whenever he shifts his position like this, now fluid will go down and air will come up. Now if I percuss in that area, the previously dull note will now get shifted to resonant note. So what is this phenomena called as shifting dullness? Now I am going to place my stet on the patient's chest and I will vigorously shake the patient. So when I vigorously shake this bottle, what did I listen? Splash. So same thing when you listen with your stethoscope, it is called as succussion splash. So previously when this bottle was completely filled with water, pleural effusion, there will be no splash. whenever there is air and fluid, then only you will get a splash. So this phenomena is called as succussion splash. So three important findings: straight line of dullness, shifting dullness, succussion splash. Along with that, there is a old finding called as metallic sound of coin. Nowadays it is not done, just for historical purpose I'll explain. See, what you do is, consider this patient is having right hydropneumothorax. On the left side it is normal lung. So what I do is, I put a coin first on the normal lung and my stethoscope will be on the posterior portion of the patient. I ask my assistant to hit on that coin. So whenever he hits on that coin, there will be a metallic sound generated. Now this metallic sound has to travel through the healthy lung parenchyma and reach posteriorly my steth. So what does healthy lung parenchyma contain? Alveoli. So these alveoli, so this well expanded lung is containing alveoli, and these alveoli effectively filter this sound. Because alveoli are filtering this sound, posteriorly you cannot clearly appreciate that metallic sound. Now the same thing I am doing on the right side. Right side patient is having hydropneumothorax. I should not place the coin on the hydro part, I should place it on the pneumo part. Again, anteriorly coin, posteriorly I will place my steth. I will ask my assistant to hit on that coin. So whenever he hits on that coin, again a metallic sound will be generated. Now this metallic sound, because your lung is getting compressed, see, the lung has got compressed because of the air. Now whatever present here is pure air. So now the sound travels through pure air. So pure air will not filter this sound. It will conduct it as it is. Because pure air is not filtering the sound, even if I am talking, you all are able to listen. So because the sound is passing through pure air, the metallic sound can be heard posteriorly very well. Why not heard on the healthy lung? Because healthy lung has well expanded alveoli. Alveoli have the property of filtering the sound. But here the lung containing alveoli has compressed. There is only pure air. So sound will pass through pure air without filtering, and posteriorly you can hear metallic sound very clearly. So the clinical findings of hydropneumothorax you can easily remember. Everything starts with the letter S. First S is straight line of dullness. Straight line of dullness. Second S is shifting dullness. Third S is succussion splash. Fourth S is sound of coin. Well heard. On all these are seen on diseased side only. Well heard on diseased side. So sound of coin is nothing but the metallic sound. The findings of hydropneumothorax, everything start with the letter S. Straight line of dullness, shifting dullness, succussion splash, metallic sound of coin, well heard on diseased side. In this lecture we have discussed what are normal breath sounds, what are abnormal breath sounds, what is bronchophony, egophony, whispering, pectoralici, and how to clinically and radiologically differentiate fibrosis, collapse, consolidation, pleural effusion, pneumothorax, and also hydropneumothorax. So very important concept for your exam students. Now coming to the old pattern of questions, completely black and white, you think you can solve them very easily. All these are one-liners and simple questions. They'll ask what is the most common cause, what is investigation of choice. Now coming to new pattern of questions, colorful. They can ask you clinical scenario based questions. They can ask you instruments, ECGs, chest x-rays, what not, and definitely it is a very dangerous pattern, new pattern. You should be very careful, students. And nowadays whenever you are attempting an exam, MCQs options will be like this. You feel everything is known to you. Sometimes it is very difficult to find out the odd man out. So in this also I don't think option D is odd man. I think he fits very well into these options. So MCQ options will be like this only. Sometimes you feel everything is known to you. Your expertise lies in removing the option that is not correct in the given question. Now one such new case scenario based question is this. A 65-year-old male presents with progressive shortness of breath other than heavy tobacco use. Patient has a benign past medical history. Breath sounds are absent 2/3 on the way on the left of the chest. Percussion reveals on the left chest dullness. While you place your hand on the left of the chest and ask the patient to tell 99, no tingling is appreciated. Trachea is deviated towards the left. Which of the following diagnosis is most likely? Whenever they ask you any clinical scenario based question, 3 steps. First thing, you should identify what is the diseased side. Second step, is it a pulling lesion or pushing lesion? And with the given data, what can be the probable diagnosis? With the given data, what can be the probable diagnosis? Let us see one by one. Diseased side. When movements are not given, we can go with breath sounds. Breath sounds absent on the left. So it is a left-sided disease. Is it a pulling lesion or pushing lesion? Trachea is also towards left. So it is a left pulling lesion. Pulling in the sense you have two possibilities. It has to be either collapse or it has to be either fibrosis. Now if you notice here, breath sounds are absent. It is a left-sided collapse. It is a left-sided collapse. Now what might be the reason for this collapse? Patient is elderly. Heavy tobacco use. What must have happened? In his bronchus, a tumor must have developed, resulting in bronchial obstruction. Because of that bronchial obstruction, he might be having collapse. So coming to probable diagnosis. So this is a left-sided collapse. Left-sided collapse due to bronchial obstruction. Why this bronchial obstruction is happening? Because of some malignancy, probable malignant etiology. This will be the complete diagnosis. Left-sided collapse due to bronchial obstruction of probable malignant etiology. Out of all these options, which will fit? Option C will fit. Now few students will be thinking, why not it is pleural effusion? Pleural effusion, my dear students, is a pushing lesion. If disease was on the left, trachea would have been towards the opposite side. Whereas pneumonia, it is an acute respiratory illness. So there are no features of acute respiratory illness such as fever, cough, shortness of breath. So the best answer here is left-sided collapse due to bronchial obstruction, probable malignant etiology. So the answer is option C. Very important concept for your exam.